Okay. So hi everyone. Welcome to the first HBI 101 event of 2021. So today is Anesthesia 101. Anesthesia is a topic that I think is deeply mysterious and interesting to a lot of us. And today we're really lucky to have with us one of the world experts in this topic, Dr. Emery Brown. Dr. Brown is a professor both at Harvard and at MIT. So at Harvard, he's a professor, the Warren M. Zapol Professor of Anesthesia. At MIT, he's the Edward Hood Taplin Professor of Medical Engineering and Computational Neuroscience. And he's also an anesthesiologist at Mass General Hospital. And Dr. Brown has been very loyal to Harvard. He received his undergrad degree in applied mathematics from the college, then his master's and PhD in statistics from Harvard University, and then an MD from Harvard Medical School. And he is a statistician in addition to being an anesthesiologist. His research is focused really of how anesthetics work. How is it that you take a drug and that produces the state of general anesthesia? He's also a world leader in designing statistical methods for analyzing data in neuroscience. And I was just going through his list of awards, and it's incredible. So I think I'm going to tell you about the last three years. So last year in 2020, he received the Swartz Prize for Theoretical and Computational Neuroscience from SFN, which is really exciting, a big deal. And then just a year before, in 2019, he received an honorary doctorate from USC, a doctorate of science. And then the year before, 2018, he won the Dixon Prize in Science from Carnegie Mellon, which is really a huge honor, a prize that many future Nobel Prize winners have won. And he's one of the very few people in the country who has been elected to all three national academies. That's the National Academy of Sciences, of Medicine, and of Engineering. He's also a fellow at the American Academy of Arts and Sciences, where we do the CBS retreats, and the National Academy of Inventors. And he's received many, many other honors and distinctions. And so we're really lucky to have him today. And I just wanted to mention, he's offered to do something cool with questions, which is pause kind of midway and take questions on one segment of the talk. And then the next segment at the end, we'll have a larger Q&A. So yeah, feel free to type in questions in the chat box whenever you think of them, and to raise your hands and I can call on you. And with that, I think we'll get started. Thank you very much, Dr. Brown, for participating in this series.
No, thank you very much, both for the invitation and for the kind introduction. So this is going to be Anesthesia 101, and I've entitled it Deciphering the Dynamics of the Unconscious Brain under General Anesthesia. And so I'll just mention, make a few disclosures here. So the funding sources, we've had the good fortune to have the NIH Pioneer Award, Transformative R01, the New Innovator Award, which went to my colleague, Patrick Purdon, and we had the good fortune to have a program project, which I'll show you some data from here today, and the support from the anesthesia department and institutes at MIT. So this is what I'm going to do. I'm going to give you just a quick historical look back across anesthesia. I'll tell you a couple sentences about how it all began. It's important because it started here, or at least a major phase of it started here at Mass General Hospital. And then I'll talk specifically about losing consciousness with propofol and the other anesthetics. I want to show you something about anesthesia in the aging brain. And then I'll show you something about reanimation, an idea that we're pursuing, like turning the brain back on after anesthesia. So these are the main points that I want to make. I don't know what concept you have of anesthesia at the moment, but the main thing I want to show you is that under anesthesia, the brain is not turned off. It's not shut down. It's actually in a very dynamic state. And it's these dynamics that actually produce the altered states of arousal, unconsciousness, analgesia, what have you, amnesia. And then we think that these oscillations which I'm going to show you, which will be in the field potentials, are one of the primary mechanisms through which the drugs are working. It's probably not the only mechanism, but it's certainly a primary mechanism. And because they're readily visible and they change systematically with the anesthetic class, the dose of the drug, and patient age, you can use them to monitor the state of the patient in the operating room. And I'm going to show you that. And so, that's going to be a major theme throughout what I tell you. And then finally, this idea of we give you drugs to turn the brain off so it can place you in a state where you're effectively insensate and can tolerate what would be an otherwise traumatic and barbaric operation. But we don't turn the brain back on. We just let the drugs wear off. So one of the things that we're studying very actively now are coming up with ways to turn the brain back on, because one of the things that we see quite frequently, particularly in older patients, and old doesn't have to be that old, it can be just patients over 50 or so, we see a lot of brain dysfunction, cognitive dysfunction that can last for several hours up to several weeks after surgery and anesthesia. And the last thing I want to give you an idea of, that general anesthesia is probably an underutilized way to study the neuroscience, to take a neuroscience perspective on the brain. So let me start with a definition. So what is general anesthesia? So it's a drug-induced reversible state that has antinociception. Unconsciousness means you're not aware of what's going on while the surgeon's operating. Amnesia, you shouldn't form memories. Akinesia, you're not moving around while they're operating. And you have physiological stability. So this is how we earn our money as anesthesiologists. And I put the star by this, antinociception, because when we wrote this review in the New England Journal back in 2010, I didn't say this as clearly. I said analgesia. And what I'm doing here now is I'm drawing a distinction between nociception, meaning the transmission of information about harmful stimuli in the through the body, when you're unconscious, right? Because if you're unconscious, right, because pain is actually conscious perception of nociception, and technically under anesthesia we have antinociception. So it's a technical distinction, but it gets to be important when we think about how we design anesthetic techniques. And the definition is important because we're very sloppy as anesthesiologists. We just say, oh, how deep is he, or is he asleep? And one of the things I'm going to show you is anesthesia is not sleep, and thinking in terms of depth just as a one-dimensional idea just isn't the way it's not what's happening. It's not the way to think about this. So that's why I like to give the definition before I start. Now for just a little brief history. So the person who's credited with the first public demonstration of anesthesia is William Morton. So Morton was a dentist, and he realized that he could, people took very poor care of their teeth at this time, that's, back in the mid 1800s, and he could put in a nice set of dentures if he could remove all of the patient's teeth. And dentists, like surgeons at the time, were measured by how fast they could carry out a procedure, how fast they could operate. And he supposedly could take out a tooth in a little more than a minute. So, but he realized this would be extremely painful. So he was looking for a way to render someone insensate. The word anesthesia didn't exist at the time. And one of the things which was rather in vogue at the time was sniffing ether, kind of like, maybe smoking marijuana now or that sort of thing. So after a dinner, someone might sniff ether. And they have these shows which we call ether follies, where people would sniff ether and they would, get giddy and have a high. So he saw someone pass out from that at one time. He'd been talking with this chemist, Charles Jackson, and he reasoned that maybe he could use ether as a way to, put patients in a state so that they could, have dental procedures or surgeries. And he tried some things on himself. And so he had this idea that this would work. Obviously, this is well in advance of IRBs and that sort of thing. So he mentioned this to John Collins Warren, who was like one of the major surgeons at Mass General at the time. And in October 16, 1846, they carried out the first public demonstration of ether anesthesia. He constructed these really nice thick glass flasks with a sponge inside that are soaked in ether. And you can see them at the Mass General Museum right there, just right in front of the hospital there. And he soaked the sponges in ether, held the flask, the opening of the flask, in front of Gilbert Abbott. He was a gentleman who had a tumor on his neck that John Collins Warren wanted to remove. And Abbott was mesmerized, as they used to say at the time. And at the end of the surgery, when John Collins Warren was able to remove the tumor successfully with seemingly the patient in this rather insensate state, he said, "This is no humbug." That's 1846 speak for "this is no bullshit," like it really, really worked. So Morton realized that he'd figured out something important. So he called on this guy here, Oliver Wendell Holmes Sr., who was the father of the Supreme Court Justice. He was a major intellectual at the time. He was, trained at Harvard undergrad, Harvard Medical School. But in the interim, after finishing, he was actually a poet, and also, so a very learned man. And he'd spent a good amount of time studying the Code de Médecine in Paris. And so he's the one who coined the term anesthesia. Morton wrote to him. You can find this letter online. It's on the web. And Morton Holmes went through a number of different terms: anesthesia, he said it shouldn't be neurolepsia. He said, and he was rather humble about it. He said, well, we should choose the term carefully. We'll call anesthesia the state, anesthetic the adjective, because he says whatever term we pick is going to be with us now and forevermore. And sure enough, he was correct. So, and just to be sure I balance out history. So that was 1846. So by the end of the year and the first part of the year, this had already spread to Europe and people were doing it. So this had a huge impact on medicine. And I think also by the first of the year it was also being practiced in Australia. And however, this wasn't the first use of ether as an anesthetic. The first use was in 1842. And so, but the problem was that it was by Crawford Long, the Crawford Long that the hospital's named after at Emory University. He was the first person to do it, but he didn't publish his results until 1849. So again, even then, publishing was important. So this first public demonstration which really had the major impact on medicine. And it changed practice, because at the time, what people would do is they would come up with more advanced ways to hold patients down, as opposed to dealing with the fundamental problem, which was putting them in a state where they were insensate. So how do we do this now? So believe it or not, we still use ethers. And what we try to do is we choose drugs from the different categories, to sort of balance out have most of the good effects and fewer of the side effects. So you could still do anesthesia primarily with just ether, and we use ether. So isoflurane, sevoflurane, desflurane, which are all commonly used anesthetics, are still ethers. So when you look in the categories here, I have inhaled drugs. That's what I'm referring to. We'll induce with propofol. I'm going to show you that in just a second. And then you'll give a combination of, let's say, opioids and maybe inhaled drugs and muscle relaxants to maintain the state of general anesthesia. And as needed, giving drugs to raise the blood pressure, because typically these drugs lower the blood pressure. They tend to be very potent vasodilators. So this is what we call balanced general anesthesia, meaning as opposed to using a single drug, let's say just using ether, because you'll have, there's very profound side effects, you combine it with other drugs, which you use to try to target the specific feature that you're after. So let me just show you what this looks like in the operating room, because this is a lady that I took care of. You can see the date back here is 2013. She's about 60 years old. She's going to have thyroid surgery. And I'm going to give her a bolus dose of propofol. So in our operating rooms, we have EEG. So you can see there are 4 leads of EEG. So the 2 leads on the left, 2 electrodes on the left, 2 electrodes on the right. And I'm going to give her a bolus dose of propofol, 150 milligrams of propofol. This isn't edited. I'll show it to you in real time, because it gives you a real sense of how powerful the effect is and what the dynamics look like. So I'm just going to play this. Turn the volume down. So the first thing you're going to see, those are eye blooms if you haven't seen it. And now what's going to happen is this is going to get very noisy, because when you inject propofol into a small vein, one on the back of the hand, it burns like crazy. So that's what's going to happen. See all that noise there? That's her tensing up because propofol is burning. Now that's actually going to be very good from a pedagogic, because you're going to see precisely the instant when the propofol takes over and renders her unconscious, starts to have a very profound effect on her entire body. Right here, watch. Beta oscillations. Now watch large slow oscillations. Right here, she's out. Right there, they get bigger. Now watch, she's going to go into burst suppression. She's going to go flat and then burst and then flat. All right. So what am I showing you here? So here she is awake. So these are about 5 microvolts here. And so just 5 microvolts, not very much, low amplitude, sort of high frequency. And then when the propofol took effect, when I said, watch right here, you saw these oscillations here. So these are what we call beta oscillations. They're 12 to 16 hertz or cycles per second. And if I wanted to anesthetize her so that I could just, she was having a colonoscopy or something, I would titrate the propofol to this particular state right here. Then she went through D, she passed right through that and ended up with a state of this large, slow oscillations. And then you saw her go into burst suppression here, right, where she was flat, then bursting, and flat, and then bursting. And then in between the bursts, you could see that she was just isoelectric. So these last few states, and you didn't even see D. So D is the state that I'm going to talk most about. We have a combination of slow oscillation. You see the very low frequency oscillation and about a 10 hertz oscillation riding on top. So this is the state I'm going to talk the most about. But she jumped over that and went all the way down here to burst suppression. So these lower states here, D, E, and F, are exactly the states that you would see in someone who's in a coma. And so that's why another way to think about anesthesia is a drug-induced reversible coma. And the other thing which you can also readily see, and you saw in the little video there, she starts off with very low amplitude oscillations, and the size of the oscillations get to be larger and larger, highly structured, highly organized. And so this is why I was saying that one of the things which is occurring is it's not that the brain is turned off, but it's in a state which is quite dynamic, quite organized. And the way it organizes depends upon the neuroanatomy, the circuits, and the particular receptors that the drugs are binding to. So this is a typical sort of set of patterns that you would see for like propofol. There's a state called paradoxical excitation, which we can come back to at the end. But this is what you see. There's a standard transition into the unconscious state, and someone ending up in one of these states down here, where we maintain them for the purposes of surgery. Now, the way I'm going to show this is in terms of spectrograms, because there's more information if you can. There's more information if you can look at the raw trace, like I'm showing up here, and the spectrogram at the same time. So this is a plot of data which came from a young woman I took care of a few years ago. She's 19 years old. She was having a short procedure, and she needed to be anesthetized for a little over a half hour, 40 minutes or so. And so we gave her propofol the same way, about a 200 milligram dose here. So that was given here. So you can see the slow oscillation. So the way you read this is frequency on this axis here. Time is on this axis. The colors tell you how intense the oscillations are. So the redder they are, the bigger the oscillations. So at the beginning, you see large low frequency oscillations here, red, just after we induced her. So that's what these guys here are. Then she flips in, and here's that state. I'll just go back here real quick. That's this state here, D, which is a combination of low frequency, about 1 to 4 cycles per second, and then high frequency riding on top. So that's what you see here. And you can see if you read over here about 10, you can read off the frequency, and because it's deep red, it says that that's the large amplitude. So that's what you're seeing here, the large amplitude, 10 hertz oscillations, and slow oscillations. And we call those 10 hertz oscillation alpha oscillations. They're between 4 to 12 cycles per second. So if you give a young person propofol, this is the classic signature on the EEG of propofol. And then what you see is when you turn the propofol off, these oscillations disappear, and she woke up, basically over here. So this is the way I'm going to basically present these, the data, because you can actually see the frequency structure. And since the oscillatory dynamics are so important, it's going to help us understand them and characterize them. So these are the guys I've had the good fortune to work with over the last several years to do this work. Patrick Purdon at Mass General Hospital, a neuroscientist, bioengineer. Nancy Capel, my longstanding collaborator, mathematician at Boston University. Shenung Ching, one of my former postdocs, who's now in the faculty at WashU in electrical engineering. Ahmad Eskandar, neurosurgeon, was at MGH, is now down at Einstein. Eric Pierce, anesthesiologist at MGH. Laura Lewis, one of my former PhD students, is now in the faculty at Boston University in biomedical engineering, and Sid Cash, neurologist at MGH. So I want to show you one other bit of phenomenology, then we'll talk mechanism, because I showed you there's a very rich temporal dynamic. So basically, we give you a drug like propofol, we give you a drug like isoflurane, we continue to administer it to you, and as long as you administer the drug, those oscillations are going to stay there, and that's what makes you unconscious or renders you insensate or contributes to rendering you insensate. So there's also a spatial dynamic. And so let me explain the spatial dynamic that occurs across the head. So up here, these are 44 sites on the head, all right? So where I'm going to show you spectrograms. I'm going to show you these at 44 different locations at the same time. Because just like there's a rich temporal dynamic, there's a very rich way in which the waves move across the head when you go into a state of general anesthesia, or at least unconscious, I should say, to be more precise. And so the first thing I have to remind you of is a little factoid. Like if you close your eyes, so the nose is up here, the left ear is over here, the right ear is over here, and this is the back of the head. So this is someone, and he is a he. He has his eyes closed. And you probably remember that if you close your eyes and you measure the EEG in the back of the head, you get what's called an eyes closed alpha oscillation. That's exactly what he has here. You can see that you see this very rich red band here at about 10 hertz. That's his eyes closed alpha oscillation. Pretty much everybody has it. It maybe gets a little bit weaker as we get older. Maybe about 5 to 10% of people don't have it, but it's a very reliable phenomenon, very easy to produce. So what we did in these studies were, he's a volunteer, and we asked him, we're going to give him increasing doses of propofol. So you'll see the dose change here. So he has a full montage of EEG, 64 leads. These are 44 of those 64 leads. And what we're going to show you is how the oscillations move across the head as he becomes unconscious, reaching the deepest level of anesthesia when the infusion rate is the highest, and then as we back. So what you're going to see is this 10 hertz oscillation, which is sitting in the back of his head here, is going to move from the back up to the front, concentrate in the front. It's going to concentrate primarily in this area right here, sort of over the thalamus would be straight down there. And so it's going to concentrate over this whole area here. And then when we turn the drugs off and let the level of drug drop, you're going to see it move backwards. And so this phenomenon is what's called anteriorization. So let me just show you that. So I'll start the video. So no drug yet. So you'll see it up here at the top where it says baseline. Now the drug starts. So that's the first level. And each level is about 14 minutes. So you can see that it's breaking up in the back. See how it's appearing in the front, very strong. Level 2. Now level 3, you can see it's very strong in the front. And we're not even at the highest level yet. Level 4. Now watch at level 5. It's still very intense. Okay. Now, when we turn the propofol off, right, the oscillation moves backwards. And now it reappears in the back of the head. So that's anteriorization. So when you're profoundly unconscious, we would have you at that with this oscillation concentrated in the front of the head. So let's talk a little bit of mechanism. So what's going on? So propofol is lipophilic, and it goes everywhere in the central nervous systems, and it binds to GABA receptors. And it binds to GABA receptors, helps open the chloride channels, and generates this very inhibitory state pretty much everywhere. And so if you think about where it's acting in the main areas that it's acting, obviously it goes everywhere. So it's acting throughout the spinal cord as well. But in the cortex, we have inhibitory interneurons, and it's sort of missing in this picture here, but here's the thalamus here, and we have the reticular thalamus, which is a nice inhibitory network. And there's a very rich inhibitory network coming out of the preoptic area of the hypothalamus, projecting onto pretty much all the arousal centers here, which is, again, another very potent inhibitory site. So you can start to see why, if this drug is something which can go everywhere, it would probably generate a state of unconsciousness. All right, so we can draw this diagram here without doing an experiment. So this is just writing down known anatomy and putting down the fact that, propofol binds to GABA receptors. Like I just showed you a second ago, I go to the operating room, here's what I see, all right? I do an experiment like I just showed you, and I see that the alpha oscillation concentrates in the front of the head here. And I didn't point it out, but the slow oscillation was everywhere, whereas the alpha oscillation had moved just primarily to the front of the head. The slow delta oscillation here was across the entire head. So as I pointed out, this oscillation concentrated in the front of the head. And there's one characteristic of it I didn't mention. It turns out it's very coherent. And there are a number of ways that you could define that. But one way to say it is, if you took a location here at the front of the head, and you took the EEG signal over here, and you took the correlation between those signals at the alpha frequency, so between 8 to 12 hertz, that correlation is very high. It's about 0.8 or 0.9. So those areas are moving in lockstep across the head. They form together, they stay quite coherent, and then when you turn the drug off, they dissipate. So here's what it looks like. So one of the questions that was asked when that I got in advance of the talk was, has our statistical analysis work informed our modeling? And it certainly has, because when we first showed these oscillations to Nancy Coppell, she worked out a model which talked about thalamocortical oscillations, because she knew a lot about alpha oscillations and beta oscillations in the cortex, and also the ways that they could be generated in the thalamus. And so we postulated, before we'd even done the experiments, that this was likely an oscillation going back between thalamus and cortex. That is, this alpha oscillation would be. Now, so that's interesting scientifically, perhaps. So what does that mean practically? Well, I mean, as you know, many of you better than I do, the thalamus is a very important way station for information. Visual information, sensory information, auditory information, nociceptive information goes through the thalamus. So if you could tie up the thalamus, that would be a great candidate for making someone unconscious. And so now we've actually done the experiments both in rodents as well as now in non-human primates to actually document that there is this alpha oscillation, which is going back and forth between these two sites. So that's one component of how in this case, propofol is probably making you unconscious by generating an oscillation between the prefrontal cortex or the frontal cortex and the thalamus that makes it very difficult to have normal communications. And I'll show you a little bit more of this in detail in just a second. But this isn't the only oscillation. Look at this guy here. This guy is just as strong. Whereas this guy here is seemingly concentrated in the front of the head, the slow oscillation is everywhere. So I want to show you two bits of data that have given us insight into that. So the first piece is, and I think this is probably some of the most compelling data that we've had the good fortune to collect, because it comes from humans. So it shows us what the human brain is doing, human neurons are doing under anesthesia. So these are data which come from patients who have epilepsy, and they've come to have a resection because their epilepsy is unresponsive to medical therapy. So they come in, they get electrodes implanted, and where the presumptive epileptic foci are. And they also, in the case of our neurology and neurosurgery service, they may have some research electrodes implanted as well. They stay in the hospital for a period of 5 to 7 days after the implant. Once they seize enough and the team has figured out where the epileptic foci are, they come back, have the electrodes removed, and then they come back for a second time, a third time really, to have their surgery. So what you have when they come back the second time is this experiment is really very valuable experiment of nature. You have a human that has electrodes in the brain, so you're going to give them anesthesia. So you can actually see what the human brain does when it receives, what neurons in the human brain do when they receive anesthesia. So these field potentials here correspond to the sites on the brain surface. And here's a neuron which is recorded next to, the spike rate of a neuron recorded next to the red electrode. And now look at what happens. You can see that this neuron now spikes very sparsely. So here it's spiking pretty much wherever it wants to, but now it's spiking very much in sync with the slow oscillation. So the slow oscillation, speaking loosely, is kind of like creating these up-down states, periods where, maybe the membranes are relatively more depolarized and hyperpolarized. And so it's clear that the slow oscillation is having a very important modulatory effect on when the neurons can spike. And so if the same thing is happening at these other sites, and I'll give you a physical sense of how much this has gone down. So if the spike rates are roughly around 8 spikes per second when the person's awake, and they go down to about 1/2 to 1 spike per second. So not only can the neurons not spike when they want to, but they're spiking very, very frequently. And I can show you this better in some of the data which we've collected in our non-human primate experiments. So this is work which I've been doing for the last about 3 or 4 years with Earl Miller, and it's from the PhD thesis of Jake Donahue, an MD PhD student, here at Harvard. And so here's the animal awake. These are the field potentials. So area 8A. So, frontal eye fields up by so frontal regions with prefrontal cortex, posterior parietal cortex, and the superior temporal gyrus, so the auditory areas. So this is the animal awake. And here's the spiking activity, kind of like what I was showing you there for the human subject. And so this spike rates here, roughly around between 8 to 12, maybe 13 spikes per second. And here's the unconscious state with those slow oscillations here. And you can see there's very sparse spiking now. And not only that, the spike rates are down to about 1/2 to 1 spike per second. So the oscillations, the slow oscillations have this very, very profound modulatory effect. And not only that, but and this is something we're studying in detail, it looks like they're kind of connected maybe across the cortex. I'm not going to hang my hat on that for the moment, but I'm just pointing it out to you. But one of the key things that the slow oscillations are modulating the spiking activity quite a bit. So that's all cool and interesting, but who cares, right? So here's the thing. You know, one of the worst fears that patients have, probably the most common question that I get is, how is it that, you have awareness under anesthesia? And awareness under anesthesia shouldn't occur. I mean, I think that's one of patients' like biggest fears, particularly people who never had anesthesia before, that they're going to be under surgery, and then they're going to be awake, while the surgeon's operating on them. There's no reason for that to occur. So first of all, you have to understand something less than 30% of anesthesiologists use the EEG during surgery, and they certainly don't use it the way that I'm showing you here. And if anything that I've said is even remotely correct, if this alpha oscillation is correct and it's tying up the thalamus and cortex, these slow oscillations here are grossly modulating almost the entire cortex, making it hard for neurons to spike. If someone came to me and said, Emery, the last time I had surgery, I had awareness and I don't want that to happen again, I would use the EEG, I would dial them down, administer propofol, and I would feel very, very confident that the person wouldn't be conscious. So this is a solved problem in 2021. In fact, it was solved many years ago. But the bottom line is anesthesiologists don't use the EEG because it's still very much an empirical practice even now in 2021. So this is what I've just shown you. I've shown you how propofol makes you unconscious, this thalamocortical oscillation, this alpha oscillation. I've shown you the slow waves. I've shown you a little bit about this anteriorization. So it's not just a temporal dynamic, there's a very rich spatial dynamic. I didn't show you this information here about the brainstem, but maybe what I'll do is I'll stop and take a few questions there, and then I'll push on and tell you a few other things.
Thank you. So please feel free to type in questions in the chat box or to raise your hand.
Rick?
Yeah, Emery, feel free to defer this to later in the talk if it's better answered then. But I'm just curious about the status of these sort of unitary measures. Like years ago, there was this bispectral index that claimed that it could, by doing some analytics on the EEG signals, could give you one number that would tell you how deep the patient was. Now, what you said at the beginning seemed to argue that maybe that's not even possible in principle, but I'm just wondering what the state of the art is with that. And given that different anesthetics have different signatures that you're going to show us, I think, would the algorithm need to know what the anesthetic was in order to give you anything meaningful?
No, that's a great question. And let me answer right after I show the next about 3 or 4 slides, then it'll be very clear. And the short answer is that those ideas set our field back about 20 or 30 years. Any other questions?
So we have one in the chat box from Amy Tam. Have you ever seen unilateral EEG patterns? If yes, what was different about the patient?
Oh yeah, it's, I don't see them that often. They're usually very symmetric, but I saw one time where it was amazing. My anesthesia colleagues were putting in a paravertebral block. So a paravertebral block is what it sounds like. It's a block which is just next to the vertebra, usually about the level of the scapula. And we use it as a way to anesthetize, commonly for sort of chest surgery, very typically for women when they're having breast surgery, because it gives very, very good analgesia. So the team got the block in on the left side. They were having a little more difficulty. They were putting the one on the right. And right when they were putting the one on the right, the patient coughed. And then the next thing they noticed was she passed out. And so what they had done was they basically given her the anesthetic, tracked rapidly up into the brainstem, and she stopped breathing. And so they had to, ventilate her and then, intubate her. And it was fine because in about a half hour or so, she woke up. But to sort of see what was going on with her, how unconscious she was, the resident had the presence of mind to put the EEG on. And he put the EEG on, and the left side of her brain was completely anesthetized, and the right side was awake. And it was like the most amazing thing I've ever seen. And the other times we've seen things like that is like during carotid endarterectomy surgery, where what we do is we measure the EEG on both sides of the head, and we look for slowing on the side that they're operating on, because that means there's probably compromise in blood flow to that part of the brain. And so when we do things like raise the blood pressure, or the surgeon would put in a shunt. But the first case was just like phenomenal. It was like the dolphin brain you've probably heard about. The dolphins on the left side can sleep while the right side's awake. I actually saw that. That was probably the most amazing thing I've ever seen.
Thank you.
Other questions?
Yes, so we have a question in the chat box from Beverly Setzer.
Mm-hmm.
Why do alpha rhythms generated by thalamocortical connections localize anteriorly? Are just a subset of thalamic nuclei causing the alpha rhythm?
No, that's a good question. And what we think is occurring, so Sujith Vajayan, who's he was a PhD student with Matt Wilson and me, and then he came and did a master's degree in mathematics with Nancy. He actually studied this. And what we think is occurring is that it looks like a movement as I show it to you in the video, but really it probably represents the difference in the connections in the sort of the thalamic projections going posteriorly compared to those going anteriorly. So the ones going anteriorly have this hyperpolarizing activating current, this calcium current. So once they hyperpolarize, they actually activate, and their activation, they generate an alpha oscillation. So that's you can actually show that's very easy to do, sort of from a modeling standpoint. And starting up with a beta oscillation or gamma oscillation and driving the cortex down to alpha is very straightforward. So, and that's the frontal cortex. And so then the two couple. And it's just because when you hyperpolarize it posteriorly, seemingly those neurons don't have this hyperpolarizing activating current. So that's probably why you don't see it posteriorly. So it's really as opposed to like a movement as the video makes it appear, it's probably just one side turning off completely, the other side turning off, but turning back on, and then coupling with the front of the brain, essentially. So let me just push on to the next piece, and I'll take some more questions in just a second. All right, if I teach you nothing else today, right, general anesthesia is not sleep, all right? And this is one of the questions that I was asked, could general anesthesia be a restive state at all? So if you look here, this is someone, like I showed you, the patient who was awake just before we started anesthesia. Here's that eyes closed alpha oscillation over here. Then over here are the states of anesthesia replotted, going down to burst suppression, the slow alpha oscillations here, and then the burst suppression, the isoelectric state. Remember, sleep is different, right? So what we do is when we anesthetize you, I give you propofol or isoflurane or sevoflurane, and I hold you here while the surgeons operate. Then I turn the drugs off and you reemerge, you go back in this direction. But sleep is not that. Sleep, you start in non-REM 1, go to 2, go to 3, then up to REM, so forth. And you do that, 4 to 6 times a night. It's about 90 minutes per cycle. And, slow wave is probably the most profound state of sleep, and REM sleep is closest to being awake. In fact, you have microarousals very much around the time of REM events. So you're going between REM, non-REM, REM, non-REM. That is not sleep. That is not anesthesia. And so there's no way that using a single anesthetic, you can generate the sort of the two-state dynamic, REM, non-REM state, that's required for physiologically restful sleep. If the REM state, you're doing some work where you're pruning, maybe shoring up connections, and during the non-REM state, non-REM 3 in particular, you're probably resting. Anesthesia is not that at all. And it's worth pointing out that, a number of the sleeping medications work by GABAergic mechanisms. And so as opposed to calling them sleeping medication, if you call them mild sedatives, because that's what they do, they sedate you, then the idea is that by sedating you, maybe your natural sleep mechanisms take over. That would be a more accurate statement. So, but general anesthesia itself is not sleep. And I'll just throw in one little factoid here. So, so Michael Jackson was trying to, use propofol in particular to try to sleep. And these patterns are patterns from propofol. And what he was doing was he was actually probably sleep depriving himself because he wasn't able to get into these sort of states because he has this infusion running the whole night, you know, while someone is supposedly like watching him. It was extremely dangerous. And eventually he was going to kill himself because the drugs are just that, are just that potent. So anesthetics are not sleeping medications at all. And so this is what Rick was alluding to. So here's propofol, here's sevoflurane, here's ketamine, here's dexmedetomidine. All right, sevoflurane and propofol are both GABAergic drugs. Ketamine is an NMDA antagonist, and dexmedetomidine is an alpha-2 agonist, alpha adrenergic agonist. So if you look at them in their time domain traces, you can see that they have different patterns here, which are more readily visible when you show their spectrogram. And so Rick was asking me about the idea of having a single drug, a single index, which could tell you everything. And that's just very misleading, because what you really need to understand is you need to know the drug which is being administered. You have some idea of the dose range and the age of the patient. And so drugs in the same class, so drugs, GABAergic drugs, have very, very similar patterns because they're acting on the circuits the same way. Ketamine here, which I'm showing, you see it has this is someone who's sedated on ketamine. And they would hallucinate in this state here once they woke up. This is at 30 hertz here, which is different from the 10 hertz oscillation that you see in propofol, or let's say over here in sevoflurane. And a big difference between sevoflurane and propofol is you have this additional oscillation here in the 4 to 8 hertz range. And this is dexmedetomidine. So if you ask which of the anesthetics that we have come closest to approximating some aspect of sleep, it's probably dexmedetomidine here, because if you look at how it acts primarily by turning off those arousal centers in the brainstem, which is supposedly associated with the start of the onset of non-REM sleep. It's in a very similar mechanism. So, and then the other point is here, we can go through and do a very deep dive into the circuitry the same way I did for propofol with the other drugs as well. So different EEG signatures are associated with different mechanisms of action. That's very easy to see once you just look at the anatomy, and something which we're looking at the dynamics of now. So my colleagues I just want to tell you a little bit about aging. So this is work we did with Laura Cornelissen, Shuna Keiju, who's now the chief of anesthesia at Mass General Hospital, Sung-In Kim, who's one of my postdocs, who's now back in Korea, Chuck Birdie, my colleague at Children's Hospital, and Patrick Perdnigan, whom I mentioned before. So here's propofol in a 30-year-old. So you've seen this pattern before, the 10 to 12 hertz oscillation, alpha oscillation, slow oscillation, slow delta oscillation here. So that's someone who's 30. So here's someone who's 57, okay? So you can still see the 10 hertz oscillation. In fact, if you look at it, see how this one goes between 10 and 15 hertz, and this one is down between about 8 to 12 hertz. That's very typical. It's shifted down to a slightly lower range, and the amplitude is a little bit less. It's less red, but it's still there. And then here's the 0.1 to 4 hertz oscillation, the slow delta oscillation, all right? Now here's someone who's 81 years old. This is a woman I took care of a few years back who had a tumor on her chest the size of an American football, and it took the thoracic surgeons the better part of 6 hours to remove it. And not only look at the real absence of oscillations up here. So remember, your cognitive rhythms are up here, you know, above 35 hertz or so. And she has very weak alpha oscillations and and also weak slow oscillations. And this is very typical with aging. You know, we see the oscillations become weaker, you know, as we age. And I was able to give her 1/3 of the already age-adjusted dose of propofol because I was watching her EEG and I was able to wake her up on a dime. So this is, in particular with older patients, the value of using the EEG is probably the greatest. Now here's something which is rather interesting. So these two guys are roughly the same age. His EEG looks like hers, whereas his EEG looks like his. And, you know, when you first see this, go, wow, that's interesting. Why would that happen? Well, we age different physically. Our brains certainly age differently as well. But then what's wild about it is maybe anesthesia is a way to see it. And if you forget about anesthesia for the purpose of putting someone in a state so they can have surgery, you think about using it as a neuroscience experiment. So my neuroscience experiment is I'm going to give you a stimulus, and the stimulus is going to be propofol, and the propofol is going to make your brain circuits oscillate. Well, when you're young and healthy, they oscillate like this, and as you get older, they oscillate like this. So how we make that transition, you know, depends upon maybe how good we've been to ourselves. And, maybe this might be sort of a diagnostic way to get some sense of like brain age. I put this in quotation mark because we haven't done this, but this is something we see repeatedly in the operating room. There are differences there are differences with age, and that some people have seemingly aged faster than others. So you can probably guess what the kids look like. So there's a 3-year-old and there's a 14-year-old. The same pattern is evident across across all the age groups, but it's much broader here, and it gets narrower and narrower as we age. So going back to Rick's question earlier, if you build an index which made measurements from the spectrum, let's say here around, let's say around 20 hertz. So there's very little power around 20 hertz in an adult, young adult. And you took the ratio of this to that here, that's going to be a low number because this is going to be low, this is going to be high. Now do the same thing over here in a kid. So you do this in a kid, right? It's high here and it's high there. So that's going to tell you the kid is awake when the kid is actually well anesthetized. It just has a different dynamic. And so you can't boil this down to one number. You have to know, like I was saying before, the age, the drug, and sort of where you are in the dosing regimen. Then you can make a very reasonable inference about whether someone's unconscious. And just to sort of highlight this, so when you're very young, you actually have quite low amplitude oscillations. And the amplitude of the oscillations reach their peak somewhere around 6 to 8 years of age. This is just an empirical observation we made from just looking at data across the age range. And the amplitude of the oscillations decline with age like this. And then the 81-year-old lady is, somewhere sitting out here, basically. So the oscillations change very dramatically with age. And I just want to show you something which is just very practical. So here's the other bit of the age spectrum I didn't show you. Kids between 0 to 3 months of age just have slow oscillations. They don't produce the alpha oscillation at all. Something magical happens at 4 months of age. At 4 months, you start to see the alpha oscillation. And then it's not until they're about 11 to 14 months before you see the anteriorization, the movement that I showed you. And what we think of, this just represents a very young stage of development where probably the thalamocortical connections haven't been as well, established. Here's another case which I've hinted at already. You see slow oscillations when someone's older, and you see like a very profound absence of the alpha oscillations. And this probably just represents normal aging. So if you think of a neuron that's been around, in this case for 78 years, the myelin breaks down, the dendrites don't retract and extend and retract as much as they would when the person was younger. You don't produce as much neurotransmitter. The neuron is susceptible to oxidative stress. The mitochondria don't work as well. So you can understand why you wouldn't transmit the electrical impulses as faithfully when you're getting older. So this is, let's say, like aging. And another case, which is actually very relevant now, given COVID, is, patients who are septic show slow oscillations also. This is, I could have crossed this out and just put a 30-year-old gentleman with COVID-19 infection, and his EEG would look very much like this, in the ICU, intubated, this sort of thing. And this is probably sort of a hyperphysiologic response in a sense where the inflammatory mediators actually bind in the brainstem and turn off the arousal systems. And so you can imagine someone who has overwhelming sepsis, you're going to see like a very, very profound turning off of those centers. And it's not surprising that you have slow oscillations. So 3 different slow oscillations. The EEG looks the same, right? So here, here, and here, but they're different mechanisms. So this is developing brain. This is probably an older brain, maybe some measure of neurodegeneration. And this is the brain of someone who is quite, has quite a bit of inflammation, right? So the last thing I just want to tell you 2 sentences about is this idea of reanimation. So this is my colleague, Ken Salt. He's been working on this for about 10 years or so. So back in 2011, the New York Times did a piece on our laboratory. And this is one of the letters that came into the editor. It said, I had had my first corrective surgery for infantile paralysis in 49. That's polio, for those of you who are maybe too young to realize that. The bill for the anesthesiologist was $400. My mother was horrified, but my father calmed her when he said it was probably $50 for the procedure, but I gladly paid the other $350 because he knew how to wake her up, right? You hear this all the time. Like I tell people, you go to a cocktail party and people go, you're an anesthesiologist, you knock people out. I go, no, any fool can knock you out. I bring you back. That's the key thing. And so, but we don't really actively bring you back. We just turn the drugs off and sort of let you wake up. And Ken has been working on ways to sort of, you know, wake rats up from anesthesia so that we can eventually do this in humans. So here's a rat that's anesthetized. He's been this way for about 20 minutes or so. And what Ken is going to do is inject Ritalin, the same, you know, methylphenidate, the same Ritalin that's used to treat ADHD. So he injects it. Now he has to flush it in to make sure that it gets in. Now we don't turn the anesthesia off, right? He just injects the Ritalin. So the animal, you can clearly see there was a state change immediately. Now he has to turn over for this to count, and because that's sort of the measure of whether the animal is in quotation marks awake, right? So he's going to have to flip over. He's going to have a little hard time doing it because he's managed to get his feet caught in the wires there. You can see that. But you can see he's making very concerted, obvious effort to turn over. And he just makes one more. I think he makes it, one more. There he goes. Okay, so he made it. All right, so that's good. All right, so he did that. So before we talk mechanism, let's talk about what I call signs from the word on the street. All right. So this was in the New York Times back in April of 2015. I think it was the cover. I think it was a cover article, a front page article that day, and it was about this woman who has a startup company. So it's 11 o'clock at night. She gets this call from her investors telling her they want a new financial plan on their desk the first thing in the morning. So she calls up her drug dealer, who comes up to her apartment. He gives her a bag of pills. She gives him a wad of money. She gulps down one, and then she takes another one. And then she feels her, you can see right here, she said, several minutes later, I felt my brain snap to attention. Then she worked until 7 a.m., slept for a couple hours, and at 9 o'clock, got up and went over to deliver the new financial plan. So this is something which is very, very typical. People in high-stress jobs who start self-medicating with these stimulant drugs like Adderall or modafinil or Ritalin. Now, don't misunderstand me. This is bad. This is very, very dangerous. But there are people who do this. And the one thing that they tell you is, you see how she said her brain snaps to attention, right? They can feel that their heads like really clear up. So the word on the street says, maybe this is something we should probably do after anesthesia when your head is all foggy because it's been in these oscillatory states for extended periods of time. So let's look at another experiment that Ken did so the animal got up and maybe he was groggy, but could he actually do any work? So what Ken did next was he trained the rats to execute a behavioral task. So they touch a light, and if they hit the correct light, they turn around and they can get a reward, and they go back and forth. So what he's going to do now is he's going to anesthetize the animal and have a stimulating electrode in the ventral tegmental area. So the ventral tegmental area, we usually think about as a pathway starting sort of the origin, the mesocortical pathway in the brainstem, but it's also important. It's also the origin of this arousal pathway. We think of for reward, but it's also important, the arousal pathway, the mesocortical pathway going through the limbic system up to the cortex. I'll show it to you in a second. So he's going to have an electrode there. He's going to anesthetize the animal. He's going to stimulate, wake the animal up, leaving the anesthesia on. The animal's going to wake up and realize, oh, I'm back in my work chamber. So it goes back to work. The anesthesia is still on. He's working because you're stimulating this area to counteract the effect of the anesthesia. And then what's going to happen is when Ken turns off the stimulation, he's going to go out. So let me show you this. So there's the animal. He's anesthetized. Now Ken's going to turn on the stimulation. So he turns it on, 40 hertz. So the animal wakes up. So he looks for food. Nope, there's no free lunch. You got to work. So he turns around. So the light comes on. So he hits this bar, right? Turns back around. He gets food. Okay, so he hit the correct one. So he waits again. So hits the correct one again, right? Turns around, a little wobbly, but still he's working, right? So he's carrying out something cognitively. And I think he gets this one wrong. Let's see, yeah. So he turns around, hits the light over here. So the light tells him that he did it wrong. Okay. So no reward. So now he's going to turn around again here. And now Ken is going to turn off the stimulation. So he turns off the stimulation. And the animal's out again. All right, so he's like manipulating this animal's level of arousal. So what is he doing here? So this is that pathway I was talking about. So the ventral tegmental area here, so sitting up here in the midbrain, goes through the limbic system, then up to the frontal cortex. This is a dopaminergic pathway. And it's distinct from the nigrostriatal pathway, which is here, which is, obviously the lack of dopamine in this pathway is associated with Parkinson's disease. So, but, we usually think of this pathway as being important for reward, but it's also important for, for cognition. So in administering Ritalin, which blocks the reuptake of dopamine at the, the presynaptic reuptake of dopamine, you can see why this would be sort of would generate arousal. And then here, we've also done this. I just showed you electrical stimulation, but Ken's also done this optogenetically, going specifically after the dopamine neurons, and in fact, the D1 neurons, to demonstrate that, this pathway can be used for arousal. So this is something we're studying because we think it has very important clinical implications. So I've shown you that the brain under general anesthesia is dynamic. It's not turned off. I've shown you the mechanism of action. One of them is through these oscillations. If what we see in the monkey is what's happening in the humans, the modulation, particularly by the slow oscillation or the tying up of the thalamus and cortex with the alpha oscillation, are what are contributing to these altered states of arousal, in particular in consciousness. It's a way you can monitor the brain state, because you can see in the EEG, they change systematically, as I said, with anesthetic class, dose, and patient age. You have to realize that it can't be a one-dimensional phenomenon. And then turning the brain back on is something that we should do now, because it would probably speed recovery and reduce postoperative cognitive dysfunction. And this idea of using anesthesia as a way to study the brain, I think, as I've suggested there, is underutilized. There's so many connections to a lot of very important problems in anesthesia, where anesthesia actually serves as a model for it. And so just a couple real quick. So schizophrenia, for many years, ketamine has been a model for schizophrenia because of it creates this very active cortex, active kind of disconnected cortex. But now we use ketamine to treat pain. And as you know, low doses are now quite effective in certain patients for treating chronic depression. And methylhexatol, which is a barbiturate, at low doses actually induces seizures, but at a higher dose, like other barbiturates, can be used to actually control seizures. So there are all these things, little allegories that, they're stories for the anesthesiologist, but they're not taken seriously from a neuroscience standpoint. So if we were to do that, we would be much better positioned to actually improve anesthesia care, but also to contribute to and draw from, other areas of clinical neuroscience. So that's what I'd like to see us do. So I'll stop there. Thank you very much.
Thank you for that wonderful talk. Feel free to raise your hands, ask questions. So I see there's one question in the chat box that I can get started with from Netta. Are the differences in brain oscillations between young and old brains indicative or relative to Alzheimer's or to other diseases?
So these happen. So that's a very good question. So they're there even without having to invoke Alzheimer's. And another, so those sort of changes that you see are very, very typical with just aging. Just what we might call typical aging, independent of Alzheimer's. So you don't really need that to sort of invoke the changes.
Josh?
Hi, Emery. I was really fascinated by this idea of the sort of older brain and the younger individual. And I would imagine that it would be possible to, at least anecdotally, sort of look at those people and see, are there behavioral or cognitive differences when they're awake? I'm sure you must have thought about this, and I wonder if you had a chance to do any of it.
Yeah, so like Hiroka Kunitake, who's a GI surgeon, Mass General, is actually looking at this with my colleague Patrick Purdon, who I mentioned a second ago. So the place where they see it fairly routinely is in patients who come for surgery after having had chemotherapy. And in fact, there's this thing called Chemo Brain.
Yeah.
And I was just reading a case study that they wrote up a few days ago of a 30-year-old woman who had had, extensive chemotherapy prior to having her colectomy, and her EEG looked like someone who was in the 70s or 80s. So what they're doing is they're actually trying to study it systematically, to try to see if it can be characterized. And I'm pretty sure you can, because it probably reflects, and we can start to even, postulate mechanisms for it. And then what it really says is that you probably don't need nearly as much anesthesia. She's 30 years of age, so people would tend to treat her like any other 30-year-old. And, her brain is probably more like a 70-year-old, so she probably can use just a fraction of the anesthesia you would typically give her. And now imagine you actually gave her something to wake her brain up. That's probably what should happen to her for surgery care after, such extensive chemotherapy.
Thanks.
Mm-hmm.
So next up is Rick.
Hey, Emery, that was really fascinating
Thank you.
and useful. I'm curious, you mentioned how few anesthesiologists are using EEG in the OR, and I'm wondering, to what do you attribute that? I mean, I know that it can be difficult to get good quality ePhys signals just because of the noisy environment in the OR. Is that the problem? Is it a technical thing? Or is it that they're ignorant and they don't know how to interpret the signals, or something else that I haven't thought of? It's
really a cultural phenomenon. So there are two things. So first of all, the EEG, I'm glad you asked the question, because it has very practical implications. It's a cultural phenomenon. So we learn to give anesthesia without looking at the EEG. You kind of judge based on, is the guy moving? Is his heart rate and blood pressure up? Do you think you've given him enough based on, what you've been told before? And you basically kind of guesstimate, essentially. And people have gotten very practiced at guesstimating. Then what happened was, as you mentioned, BIS came along, and BIS made it too simple. BIS said, all you got to do is look, you anesthesiologist, don't worry about it. We've got this worked out for you. The scale's between 0 and 100. And all you have to do is keep the range between 40 and 60, and someone's they have a perfect depth of anesthesia. That's the term they were using, or they use. And so that means that you don't have to think about the drug you're giving or anything like that. So they simplified it too much. So clearly, there are cases like ketamine, like I'm showing here, where you have this high frequency oscillation. You can have a high frequency oscillation, someone could be quite unconscious. Or dexmedetomidine here, which is just the opposite. You have a low frequency oscillation, but the person can be aroused. It's different from the slow oscillation you have here with propofol. So what that did was that set our field back, and it made people skeptical of the EEG. And so this right here, this is our educational website. We're really trying to teach people how to do this. And it works against us, because people think that, oh, well, you guys are just the next sort of BIS coming along, kind of like the next, snake oil salesman coming along with, some ideas, and they're going to be debunked, also. But I'm glad you mentioned the question about the strength of the signal. I'm just going to go back to this plot here that I showed you in the beginning. This is the strongest EEG signal there is. Of all the things the EEG is used for, the EEG under anesthesia has the highest signal to noise ratio. Better than sleep, better than these cognitive studies that people do, better when you're looking to track someone in coma. Because what happens? You actually saw it in the video. See, once the drugs take over, the person doesn't move. There's no movement artifact. So you have pure signal coming out of the brain. This is really what the brain is telling you that the person is doing. And so it's ironic. We have the strongest EEG signal there is, and we're the ones who are least likely to use it. And the people who are paying for it are our patients.
Wow, that was a really good question. So then next up, we have a question from James in the chat box. So do you think that the thalamic reticular nucleus plays a role in pacemaking the thalamocortical alpha oscillations, considering the role of the RTN in sleep spindles and the suppression of thalamocortical activity during non-REM sleep?
We think it does. In other words, so the model that we worked out, I didn't put in a slide that has the details in it. It has So thalamocortical connections, cortical thalamic connections, and those cortical thalamic connections being modulated by the TRN. So yeah, it definitely plays a role in the production of the alpha oscillations. And we're able to show that, we're able to simulate very readily the patterns that I was showing you there of moving from the beta oscillations down into the alpha oscillations. So I think we think it's crucial to that to that formation. And then we've done some other studies where we've actually optogenetically stimulated the TRN to try to produce like slow waves up in the cortex. We did this in rodents about 5 years ago. And so by getting the area, so if you do slow wave stimulation in the area of the TRN and measure in the area of cortex that the projections coming out of that region are projecting to, then you can actually see slow oscillations, kind of like little micro sleeps. So if you could control the TRN, you probably could, generate a state of unconsciousness, but it's a challenge to do because it's a net, like basically around the thalamus. So I think it does play a pretty important role in the phenomena that I was showing you.
Thank you. So I had a question that's not really totally well formulated, but when you were talking about how you might study mechanisms, I started thinking about genetics. And I was curious, so when an anesthesiologist sees a patient, you were talking about how you might consider age and how that might impact things. Are there any genetic, disorders of the brain where you think the baseline might be different and you might start thinking about anesthesia differently?
To first order, no, really. I mean, because it's really the genetic problems that we see, the ones that at least for our board exams, and these are board questions, so they're things you have to memorize well in advance, because you don't see them that often. Is like malignant hypothermia, which is basically you give a triggering agent like succinylcholine or let's say one of the inhaled ethers, and they enter into a hypermetabolic state. But it really is the neurocircuitry to first order that really gets to be important here and has been sort of underutilized. In other words, I would spend 99% of my time working out the ephys, and only 1% of my time trying to work out the genetics, because the ephys is probably where the answer is. Now, having said that, it just so happens that just a few days ago, I took care of a patient that had a mitochondrial disorder. And in this case, you can't use any of the GABAergic drugs. So no midazolam, no propofol, no sevoflurane to anesthetize him. And so I used the combination of ketamine and dexmedetomidine, which, for those of you who are, animal neurophysiologists, ketamine and xylazine is basically a very standard, animal anesthetic. So that's what I actually did for him. So those cases are fortunately like very, very rare. So I think we really just need to put our emphasis on getting the neurophys right, systems neuroscience and the recordings right. And I think we're going to learn a lot. The genetics is probably second order, maybe even third order in terms of importance.
Thank you. Are there more questions? Okay. I guess if there are no more questions, we can wrap things up. So thank you so much, Dr. Brown, for your wonderful talk. That was really interesting and really broad overview. And yeah, we really appreciate it. And I just wanted to mention, if people have ideas for other 101 series, requests, please reach out to us. We have synapse elimination 101 coming up later, as well as headache biology in February. So yeah, thank you very much, Dr. Brown.
Great, thank you for having me. Thanks, guys. Rick,
thanks,
Josh,
Emery. That was fantastic.
All right, see you guys. Thanks a lot.
Thank you.
Thanks for all the questions.